Dr. Chiesa, what I have for you here is some basic questions initially as we try to understand what atopic dermatitis is. Then go on to some associated comorbidities and then talk about later research and treatments. This way, I hope we can explore the impact of atopic dermatitis from multiple perspectives. So to just start off, let's begin by defining atopic dermatitis.
Yeah, so that's a great question. Now, atopic dermatitis or eczema, those are terms that are oftentimes used interchangeably. When you think about atopic dermatitis, we're thinking about a disease that's chronic. It's an inflammatory skin disease that presents with areas of inflammation. When we talk about inflammation, we talk about areas that are red. They can show increased thickness of the skin, scaling, and dryness. And perhaps the hallmark symptom of atopic dermatitis is itching. And itching is a significant morbidity in this patient population because it can lead to impacts in sleep loss. It can also lead to impacts in decreased quality of life. Now, in its more classical form, particularly in children, it tends to affect the folds of the skin behind the elbows, behind the knees. Anterior to the elbows or behind the knees. However, the clinical presentation can be quite varied in other patient populations. For example, in adults, it might just present on the hands, or it may also involve extensor surfaces, which are not the typical surfaces involved.
Dr. Chiesa, so is atopic dermatitis different from eczema? And if it's different, then what makes it different?
Again, as I previously mentioned, those are terms that are used interchangeably. When we talk about eczema, we're talking basically like an umbrella term, right? And there's different types of eczema that could go within that group. You could talk about nummular eczema, dyshydrotic eczema. You can also talk about atopic dermatitis. But for the most part, and I think for our discussion with our lay audience, we'll use both terms interchangeably, meaning atopic dermatitis referring as eczema, and either way. There's no clear diagnosis to distinguish atopic dermatitis or eczema. There are certainly some criteria scores that are used, but those are basically used more in clinical trials or research, but they're not really used in clinical practice on a daily basis.
Mm-hmm. So as I just mentioned, that the condition is not restricted to children, and it's an adult disease as well. So can we talk a little bit about the prevalence of atopic dermatitis?
Yes, of course. So when thinking about atopic dermatitis or eczema, most people and even most providers will still think of this as a disease primarily affecting children. And that is partly true. We know that the prevalence of eczema in the pediatric population is quite high. The prevalence worldwide has been reported to vary between 10% to 25% of the population. We know that in the United States, the prevalence is closer to about 13 to 15%. And we used to think that most patients with atopic dermatitis who were pediatric patients would outgrow their disease. However, this has been rather quite difficult to study. And in fact, what may be actually more common is that instead of actual resolution of the disease, what happens is that the disease severity will vary through time, meaning a patient may be more severe earlier during their lifetime, and then as they get older, it might kind of quiet down for a little bit, and then as they continue to grow older, then the disease starts to appear again and worsen in severity. When you think about the prevalence of the disease or in the adult population, it's been found in one of the studies that we're participating in, the prevalence has been described to vary between 3 to 10% of the adult population, so it's less than the pediatric population. However, in our more recent study, we found that the prevalence in the population of the United States is about 7%. And so when you put things into perspective, if we use U.S.-based census data, this would mean that we have about 16.5 million adults in the United States that would have a diagnosis or fit a diagnosis of atopic dermatitis, with about 6.6 million meeting criteria for moderate to severe disease. So this would mean that atopic dermatitis is perhaps maybe the most prevalent skin disease in the adult population as well. And there's also the idea out there that there's something called adult onset atopic dermatitis, and it's atopic dermatitis that tends to occur in the adult population. Different cutoff ages have been used, 16, 18 years of age or older, in patients who have no prior history of eczema or atopic dermatitis as a child. And furthermore, there's another entity called atopic dermatitis of the elderly, which hasn't really been quite well defined yet, but has a similar clinical presentation, and it tends to occur in patients who are older than 65.
Mm-hmm. What about the environmental effects on this prevalence?
So there are prior population-based studies in the U.S. have found that the prevalence of atopic dermatitis seems to be higher in either eastern states or states that have that are more larger metropolitan areas. So trying to kind of explain maybe it could be that patients who live in this type of environment are exposed to more environmental pollutants or air pollutants. Could it also be that patients that live in more metropolitan areas are less exposed to a number of antigens that they would get exposed to if they would live in more rural areas? We don't really know how to best explain that relationship, and certainly future studies need to address that. But there certainly is an environmental component to atopic dermatitis, and we can see that in, for example, studies that have been done in countries that have been less developed in the past and now are being more developed, such as Ethiopia, where the prevalence of atopic dermatitis has also increased through time.
Mm-hmm. So I have another question here. We have already talked about the environmental effect on atopic dermatitis. But we also know atopic dermatitis is not contagious. But we've seen that more than one member of a family may be afflicted. So definitely this condition seems to have a genetic component. Isn't that right?
Yes, that is true. And I'm glad that you talk about atopic dermatitis not being a contagious disease, because I think it's very important to reiterate that to our audience, that you can touch, you can hug, you can share a handshake with a patient who suffers from eczema or atopic dermatitis, and you will not develop this disease. Certainly, patients with atopic dermatitis do have a strong family history of atopic dermatitis. And this has been shown to be more consistent in the scientific literature. For example, approximately about 70% of patients with atopic dermatitis do have a positive family history of atopic disease. And studies have also shown that the odds of developing atopic dermatitis are 2 to 3 times higher in children who have one atopic parent, and up to 3 to 5 times higher in patients who have two parents who are affected with atopic dermatitis. So it's important to understand that. And when you think about the genetic components of atopic dermatitis, perhaps the most well-studied and known genetic risk factor for eczema is the filaggrin gene. So multiple loss-of-function mutations in the filaggrin gene have been studied in the literature. So this gene, for those of you who are not familiar with it, codes for a protein called filaggrin, or filaggrin aggregating protein. Now, this protein is an important component of the skin barrier, and it's partly responsible for development in barrier. So when you do have mutations in filaggrin, you have increased loss of water or transepidermal water loss. You also have exposure to antigens that can penetrate the skin, and they can sensitize our immune system through percutaneous exposure. It's also been shown that patients who have mutations in the filaggrin gene have more persistent disease. These studies, it's important to know that the majority of these studies were done in Caucasian populations of Northern European descent, and as well as Asians. And for a time, we understood these to be less prevalent amongst other races or ethnicities, such as African Americans or blacks. However, a recent work by one of my mentors, Dr. Margolis, and his team at the University of Pennsylvania has shown that African American children do in fact have mutations in the filaggrin gene. These are not the most common mutations that have been previously described, but are nonetheless present. And interestingly, his studies also showed that these were also associated with particularly more persistent disease in pediatric patients or Black or African American. So it's important to know that as well.
Mm-hmm. At this time, at this point, actually, I would like to take in one of the first questions that came in via email, and it is like, would it be right to say that eczema is 80% genetic and 20% environmental?
Yeah, I would be careful about attributing so much of a genetic component to atopic dermatitis as a primary genetic disease. I mean, when you think about the pathophysiology of atopic dermatitis, it's an extremely complex disease. There's an interplay between genetic mutations, of which I previously mentioned, the most well-known study is filaggrin, the environment as well. And I think it's also important to know that there are a great deal of patients with atopic dermatitis who do not have filaggrin mutations, and they still develop atopic dermatitis. And this would pinpoint more towards an immune dysregulation as the cause and not so much a genetic component. And in addition to that, patients who have mutations in filaggrin do not always develop atopic dermatitis. It's thought that about 40% of individuals with filaggrin mutations do not go on to develop the disease. So, yes, there is definitely a genetic component, but again, the physiology is complex, and it most likely involves an interplay between environmental factors and as well as immune dysregulation. And to whether or not, to what point these susceptibilities are genetically predetermined, I think that remains to be seen.
We are on the topic of genetics here. I have a couple of more questions related to it. It is said that allergies and asthma often develop in the same people, and that 50 to 70% of children with atopic dermatitis subsequently develop asthma. Now, I have a personal interest in this because when my kid was diagnosed with asthma, I was asked to keep a lookout for eczema as well. So it would be great to actually talk a little bit about this.
I know, and I appreciate this question because this is a question that comes a lot during the discussion with patients. And I believe the concept that we are referring to is the concept of the atopic march, or the idea that development of atopic dermatitis early in life, will often predate the development of other allergic disorders, such as, for example, asthma or food allergies. And this is an interesting area of research and focus because it's trying to, explain that if you develop atopic dermatitis early in life, could you be, in a way, exposing that immune system by way of an intact skin barrier to become sensitized to environmental allergens, right, and trigger other allergic diseases such as nasal allergies or asthma. And the idea is, to try to identify, well, if we do early interventions, if we prevent the onset of atopic dermatitis, is there a way that we can prevent the development of asthma or nasal, seasonal allergies or food allergies as well? Is there a way that we can identify, what are those environmental allergens that, could potentially contribute to modify the atopic march in a way to prevent these other diseases which can go on to become chronic, lifelong diseases from developing in the first place. And I think that's a very interesting area of research that we're trying to get at. So it's not particularly strange to see in children, both carry the presence of things like food allergies, seasonal allergies, asthma as well. I think with adult onset atopic dermatitis, the story is a little bit different. One of the questions that I typically get from my patients, adult patients come to see me for the first time is, I'm breaking out, I think this is eczema. Is it something I'm doing wrong? Is it something that I'm eating? And by the time they come in, they've been on these elimination diets and nothing is working. And when you take a step back and you look at those patients, you tend to realize that, the prevalence of food allergies goes down as we age. So I try to counsel my patients, if you're presenting now with symptoms of atopic dermatitis and you've never had this before, it's very unlikely that this is probably attributed to a food allergy. And that also brings, I think, a little bit of relief to the patients, knowing that, we're not doing anything wrong. It's just a disease coming out, and we don't really understand why it happens so later in life at this point.
In the same line of thought, as I was researching for this talk, I read that another indication that people with celiac disease are also more prone to have eczema, and relatives of celiac patients are twice as likely to have eczema. Does this is this also related to the genes or familial inheritance?
Yeah. So that's another interesting question that we also, see in patients when they come to the office. They ask the questions, could I have celiac disease? And I mean,
Yeah.
oftentimes the answer is it depends on the patient and the age of the presentation, right? We do know that atopic dermatitis, the way we think about the disease is changing a little bit, right? With the studies on comorbidities, we're not only thinking about atopic dermatitis as a disease just affecting the skin, but we're also thinking about atopic dermatitis as a disease that affects, that can also result in systemic inflammation. And associations that have been previously described include autoimmune diseases such as celiac disease, vitiligo, alopecia areata as well, or hair loss. With respect to celiac disease, it's also being studied in more detail, but prior population-based studies or systematic reviews or meta-analysis have shown that patients with atopic dermatitis may in fact be associated with higher prevalence of celiac disease. And there was a particular study that was done in the pediatric population in Estonia, which showed that pediatric patients who had a diagnosis of atopic dermatitis had about even a fourfold increased risk of developing celiac disease. So now the question becomes, should we test everyone for celiac disease? And I don't think that the answer is yes at this point. We still have to, celiac disease, it is prevalent, it is out there, but it doesn't affect all our patients with atopic dermatitis. I would suspect more or raise suspicion in a patient who is presenting with symptoms of eczema, but if it's a child who's presented with abdominal pain or intractable diarrhea or failure to thrive or other symptoms that could be indicative of a malabsorption, that's where I probably would pursue additional testing. That being said, there are patients who have celiac disease who have absolutely no symptoms, but again, I don't think that the data at this time supports that we screen all patients with atopic dermatitis for celiac disease, but it's important to know that this association has been reported and that we should keep it in the back of our minds whenever we have patients coming in who may present with any of these symptoms.
Mm-hmm. I'd like to move on right now to talk about the symptoms of atopic dermatitis. You did mention it right at the beginning of the talk. But could you please categorize it on the basis of early atopic, early presentations and late or severe condition being presented to you?
Of course. So, we're thinking about the clinical presentation of atopic dermatitis. There's studies showing that the distribution of lesions or the phenotype of atopic dermatitis can actually vary with age. For example, in very young children or infants, the lesions of atopic dermatitis, the inflammation, that redness, that skin thickening, the scaling, can be primarily localized to areas such as the face, the buttock area, sometimes the extensor surfaces. So we're talking about the interior aspect of the legs. And then as children grow older, if they present eczema, when they're a little bit older, the lesions can primarily be localized to what we consider to be the more classical sites of eczema, which are the folds of the skin, right? The elbow folds or behind the knees. Sometimes children with eczema will also present lesions around the neck area. Then adults, I think the presentation of atopic dermatitis in adults is a little bit more varied, right? And when we have a patient who's had eczema for all his life and you ask them, the question I usually ask them is, when you were a child, was your eczema primarily on the folds? And they'll say, yes, it's primarily on the folds, but now as I've gotten older, it's now appearing in other areas. And that's something that's been described. In adults, you can have eczema localized to not only the flexural areas, but also the extensor surfaces. Eczema can also be localized to just specific areas. For example, we have patients who present with eczema only in the genital area or the breast, the nipple area. We also have patients who only present with eczema on the palms, which can be very limiting because of the itching and can be very refractory to treatment. And the diagnosis is sometimes not as easy to make. So it's important to keep those considerations in mind, because if we see a patient, an adult patient who comes to our office, and we look at the distribution of lesions and we find, well, this patient doesn't really follow the more classical pattern for the distribution of eczema lesions, we may actually miss that diagnosis. So it's important to know that, particularly in adult patients, eczema can have a very wide presentation. I think one of the most important things to remember is that eczema is very strongly associated with itching, or with itch. During my training, some of my mentors and teachers would say, if it's not itching, it's probably not eczema. So take a step back and re-examine your diagnosis, because this is definitely a condition that's characterized by that. Other symptoms that I think need to be addressed when talking to patients with eczema is that because of the widespread inflammation, because of the itching, these patients will experience impact in sleep loss. They have also been shown to have higher rates of depression or anxiety. And, a patient may not say that they're depressed unless you ask about those symptoms. So that is part of my questions when talking to patients. Are you depressed? Is the eczema leading to depression? Is the eczema leading to anxiety? Because you cannot predict the flares. Are you sleeping? There's studies showing that patients with eczema may not sleep for 5-7 nights out of the week, and that's basically not sleeping any night, and that can have a significant impact, not only in their psychological symptoms, but also in their overall well-being.
Is there what is the usual routine followed in diagnosis? You said, of course, the itch is there, and there is an audience question. She wants to know: is there any blood work that is done to diagnose a condition?
Yes. So that's another excellent question. So the diagnosis of atopic dermatitis is a clinical diagnosis. It depends. At this time, there are really no specific blood tests or specific biomarkers which are routinely used to help establish this diagnosis. Typically, a very thorough history is important. That takes into account the onset of disease, the change of disease patterns through time, if there are any triggering or modifying factors, if there is a presence of other atopic diseases such as asthma, seasonal allergies, or food allergies, as well as a family history of atopic diseases, followed by a thorough physical exam, with special consideration for current distribution of lesions and morphology of those lesions, I think is going to be critical for establishing the correct diagnosis. There are times when, certainly you could use some of the diagnostic criteria that have been developed, including the Hanifin and Rajka criteria, the criteria developed by the American Academy of Dermatology. And those criteria are freely available online. We don't typically will use them during clinic, if you're in a visit clinic, because they might be extensive. And they haven't really been validated in that way. Where we typically will be using them is for clinical trials. So at this point, the diagnosis relies mainly on the history and the clinical examination. At times, a skin biopsy may also be considered in cases in which the diagnosis is not clear or the presentation is atypical, as this can help aid in establishing, a proper diagnosis. And for example, I may have patients who present with a severe flare of atopic dermatitis, and I go about their history. There doesn't seem to be a strong history of atopic dermatitis in the past. And then I suspect, am I really dealing with atopic dermatitis, or could this be something else? And a skin biopsy can sometimes help distinguish that, particularly, if you have a patient who presents with erythrodermic psoriasis, which is that they're completely red from head to toe. And patients with atopic dermatitis can present in that same way. So biopsy will often can help to distinguish between the two. In addition to that, patch testing. Patch testing is a way that we can identify if a patient has a contact dermatitis. We do know that, just for those of you out there, a contact dermatitis or an allergic contact dermatitis is a dermatitis that develops from coming into contact with something in the environment. It could be a perfume, a preservative, the laundry detergent, so on and so forth, even the topical steroids that we're using. And atopic dermatitis patients are at higher risk for developing contact dermatitis and have a higher prevalence of contact dermatitis as well. So sometimes if I have a patient who comes to me and says, my eczema has been very well controlled during the past couple of years, and it hasn't been until recently that I just cannot get it under control, and it's particularly on this area. It could be the neck, the hands, and it doesn't matter how much steroids I put on. It doesn't matter how much precaution I have. I just cannot seem to clear it. So in those particular patients, before I move on to using systemic treatments, I would say, let's take a step back. Let's re-examine the diagnosis. We could consider doing patch testing to rule out the possibility of contact dermatitis, and we've seen that in clinic as well. And the treatment for that is avoidance, and that could be life-changing for our patients as well. So that may be another thing to consider. I did previously mention about food allergies and how the prevalence of food allergies decreases as patients get older. So at this time, my adult patients, I don't really recommend testing for food allergies unless patients present with other symptoms or other clinical symptoms, such as, for example, hives, swelling of the face, the throat, or lip, to suspect that there could actually be some form of anaphylaxis. And I also think it's important when you're evaluating your patients to get a thorough assessment of what their actual skincare regimen is, because this is probably considered one of the first steps in managing atopic dermatitis. With respect to blood work, there's always the question about, well, should I get my IgE levels tested? And that's an interesting question. Certainly, elevation in total or allergen-specific IgE levels have been shown to be evident in patients with atopic dermatitis, and it seems that higher IgE levels are associated with more severe disease and disease that has a more protracted course. However, it all still remains controversial. It's not something that I would typically do to establish a diagnosis or to manage response to treatment. We do know that about 20% of people with atopic dermatitis will not demonstrate changes in the IgE, so I really cannot use them in that population. And we also know that about 50% of the healthy population in the U.S. will have elevated IgE levels. So we tend to think about IgE changes as more something happening more downstream in the inflammatory cascade and not something that's triggering the symptoms. So I will not typically test for that.